Thank you very much. I'd like to start by thanking the chair and co-chair for the opportunity to talk on this topic, which I'm very passionate about, and it's a really incredible group of people to be up here with. I know we're running a little bit late on time, so I'm going to start a little timer so I can keep myself short for everyone's sake. Video-based assessment, we're going to switch a little bit from education to assessment, and we're going to think about where we are right now in terms of assessing, using the video to assess technical skills, and what we're doing with it. I do have the following disclosures. I teach for Intuitive Surgical. None of these are relevant to the following talk, and we won't be discussing any of these. So the first is, if we think of recording video and assessing surgeon skills using a video, I would argue that the first and sort of penultimate study on this was done by Dr. Birkmeyer several years back now in 2015, and you could see the reference there where he looked at, he and his colleagues looked at bariatric procedures. So they were looking at Roux-en-Y gastric bypass. They were assessing videos of Roux-en-Y gastric bypass, just the intraoperative portion. So you're just watching surgeons and do edited steps of a Roux-en-Y gastric bypass. And they were able to associate the objective assessment of what's going on. So that means the videos were reviewed by colleagues, okay? So the group reviewed them. And through objective assessment of that, smoothness of motion, these types of domains, they were able to say, if we put these on a 1 to 5 scale and we rate them and we give them a score, that score is associated with bariatric surgery outcomes related to Roux-en-Y gastric bypass. I was fascinated by this, and the study Dr. Greenberg just mentioned earlier is the one that I'm showing here, where we published in JAMA Surgery the association of this technical skill objective assessment in colorectal procedures. And so for our assessment, what we were looking at was laparoscopic right hemicolectomies. And again, all we're doing is we're taking a video of the intraoperative portion of a laparoscopic or robotic. We had a couple that were, so a minimally invasive approach. Take the steps of a colorectal procedure, right hemicolectomy, put it on a 5-point scale. And what we were able to show is that those ratings were again associated with patient outcomes. And what you're seeing in that last slide is actually if we take that single video rating and we link it to that surgeon's NCDB outcomes, so meaning cancer outcomes, we actually are able to show separation of outcomes over long-term in cancer outcomes. And so we're starting, I would say, you know, the evidence is really there that we can use a video, we can watch a video, and we can associate it with outcomes. Interestingly enough, we got a lot of pushback where people were like, well, I don't necessarily believe that's true, right? You're just watching a video. How is it possible that it's linked to outcomes? There are some assessments out there that aren't linked to outcomes. So what we did was we separated out and we said, okay, if we talked to surgeons and we said, what are the things that would be obviously associated with technical skill? One of those would be something like unplanned reoperations. So here what we're doing is we're looking at the surgeon's technical skill on the x-axis, and on the y-axis, the risk-adjusted, so this is a hierarchical adjusted rates of unplanned reoperation. And we show a very strong association. And if we group those things that are likely to be associated with technical skills, we call that a skill-related composite, and we see there's a strong association between technical skills rated on a single video and a skill-related composite measure. The opposite is also true, which means that if there are obviously skill-related things, there are probably obviously skill-unrelated things. So things like SSI. A lot of people said, well, why would something like SSI be associated? We have all these bundles, we have all these things that we're doing. Why would that be associated with what you're seeing in the operation? And it turns out, if you look at just those individual measures and you pull them out, and then you group them into the things, so for SSI, it's not associated. And if you group them into skill unrelated, again, you show there is not a very strong association with the things you wouldn't think would be associated with technical skill. So I feel like the answer that we can use video and practicing surgeons to assess, to look at a single video and assess whether or not the technical skill varies enough to predict patient outcomes is starting to be pretty well answered. I had the privilege of talking about how do we do a better job of teaching and influencing surgeons in practice to move towards minimally invasive inguinal and ventral hernia repair, because the outcomes are pretty clearly better. If we could take two identical hernias, identical patients, we know that there's lower length of stay, less blood loss, less pain. We know that there are better outcomes. And during that talk, I did a little poll everywhere to those in the audience, okay? And I said, we're here pushing minimally invasive. We are sages. This is what we do. We're talking about minimally invasive surgical repair. So now I have a question. Imagine you have a hernia, okay? But you can only choose whether or not you're going to have it minimally invasively or open, or which surgeon will do the surgery for you. 91% of the audience said I would choose the surgeon. So on the one hand, we're going through all of this video-based assessment, talking about this like the science is there that we can assess the differences, but there's something about all of us that sort of already knew this. And when our results, we've published a couple papers now on different ways of looking at technical skills and assessment. This is a common theme. This is from Twitter. This was a Twitter user that sent out, well, surely this is not new to any of you, right? I mean, surely as surgeons, I mean, who would you have operate on you? And so I would say that we need to start moving past whether or not we think video-based assessment is actually related to outcomes, and we need to say, what are we going to do about it? And that's where this question of coaching and the ADOPT program and video-based education and everything really comes into play, where we say, okay, now that we say that we can use the video to assess differentiation and technical skill, how do we use that to get better? I would argue that outside of medicine, there is a ton of research into this. And one of the true thought leaders who unfortunately just passed away this past November, Dr. Anders Ericsson, is really the leader in the science of expertise. He studied it for his entire career. Some of the 10,000 hours work actually comes from his PhD dissertation work from 30 years ago, and he just repeated it over and over again and looked at it in lots of different fields, from violinists to athletes. And here's some information from Dr. Anders Ericsson when they're looking at medicine. He's actually looking in the medical field at performance over time. And it turns out these are general practitioners in medicine, in the medical field. But nonetheless, when you assess the expertise over time, you see a general practitioner tends to actually lose some of that expertise over time. And if you think about our medical systems and how we're training and what we're doing in practice, this slide probably isn't that surprising. When you hear him talk about and you read about the science of expertise, what they call that performance is arrested development. What they're saying is, how do we move from arrested development to expert performance, okay? Because the practice of medicine is not everyday skills. Everyday skills are things like when you're driving your car, turning on your blinker to change lanes, right? That's just the stuff you do automatically. And so while there are things that we do automatically in surgery, really we're talking about arrested development. And what you heard in the last talk with video-based education is a lot of what you can use to go from that stall to a sense of mastery. So I always like to give some reading material or some references for people. If you have not read this book and you are interested at all in this topic, this is just a phenomenal book that I now have taken to read every year because I feel like every time I read through it, I learn more. But it's Dr. Anders Ericsson and Robert Poole, and they really bring together a lot of their science that they've written about and talked about for years. It brings in a lot of the data that he has in his earlier books. It's called Peak. And in there, they talk about a lot of different things. But if I were to boil it down, you know, a lot of people talk about skill mastery and peak performance as natural talents, and they do a phenomenal job of essentially debunking that. But we hear that language all the time. Oh, we hear it when we talk about residents. We talk about, oh, that person has a lot of talent, right? Oh, there's a lot going on there, right? Oh, we hear about it in sports players. Oh, they were just sort of born gifted. They've always been great, these types of things. And he really does a phenomenal job of debunking that. One of the best examples is that for a very long time, the idea of perfect pitch was thought to be something you do not train. It is something you were either born with or not. And now it's definitively known. It's absolutely something we can train. The next is volume alone. we have been hammered into us over the last 30 plus years that volume is associated with better outcomes, and that is true. And this is where you have to recognize that association is not causation. There is a fascinating study in the orthopedic registry that actually shows some of their worst outliers in terms of outcomes are some of their highest volume orthopedic surgeons. And that's because when you focus solely on volume at the sake of other quality metrics, at the sake of other things, you can see how certain things that allow you to be faster are actually shortcuts that might not be associated with best outcomes. So volume alone is not the cause of outcomes. So where does expertise come from and what can we learn from peak? We really should learn that quantity and quality of the mental representations, like you just heard in the education talk, are critically important. That there's continuous hard work, and I would say as surgeons, that one we can probably check off. But how many of you in the room or listening online can raise your hand and honestly say that you do purposeful, deliberate practice on your surgical procedures on an ongoing basis? How many of you can say that you have formative feedback and coaching built into your regular practice as surgeons? And I would argue that if this were a room of swimmers trying to get into the Olympics, or if this were a room of violinists trying to become the principal violinist in an orchestra, they would all raise their hand. They would all tell you, these are things that I think about all the time. I think about, what am I practicing now? What aspect am I getting better at? How do I write that down? How do I make it official? And who's helping me through that with coaching? And so none of this should come as a surprise, because if we think about training surgeons right now in practice, we don't really have any methods for assuring technical competency. We have no minimum standards for competency, right? We have no guided learning over time. For graduation, we have things like case volume. Some credentialing committees say things like, oh, if you're going to do robotics, you need to have 10 cases a year, things like that. But these aren't true minimum standards, guidelines over time. They aren't mechanisms for feedback. And volume in and of itself doesn't assure competency, so what are we doing about this? I just like to put in a few plugs here. The first is that the American Board of Surgery has been thinking about this for a long time, and there's a program that was spearheaded by Dr. Mellinger and is now in full force, where they are looking into how video-based assessment can be better used in practicing surgeons to help maintain and achieve competence and actually start striving for excellence. And this is a wonderful initiative where we're really in the early stages of figuring out how do we do this on a large scale. The next is that there are a lot of organizations. Dr. Greenberg is well known for being a champion for surgical coaching and practice, and now there's the Academy for Surgical Coaching. There's a program that's going to be just after this conference and associated with this conference, but it's a nonprofit helping individuals learn how to become coaches and really starting to change the culture around coaching. When we talk about assessment, there are several organizations. These are just two of them. I don't have any affiliations with all of these groups, but these are groups that are starting to, for-profit groups that are starting to figure out, well, maybe there's a market here for assessing surgical videos, giving feedback on surgical videos, and this field is rapidly expanding, and I would say that we need to know what's next. Just real quickly, because we're a little bit over time, all I would say is that we've been integrating video-based coaching and feedback for a long time. I work with an excellent qualitative researcher, Dr. Johnson, who's been doing interviews with surgeons as to how they can get better, what they liked about it, what they didn't. There's a lot of positives about surgical coaching. They don't feel so isolated. They really enjoyed the camaraderie, getting feedback. They could tell that they were making purposeful changes when they're reviewing their own videos. But there's a lot we have to learn, and a lot of these are administrative. Like, well, how do we actually fit coaching into our daily lives? It's really hard to make time to meet with people. It's not prioritized. It's sometimes not convenient. COVID put a big wrinkle in all of this. And so what we've really learned is that video is valuable for reviewing others, for reviewing your own, and hearing a diversity of opinion. That keeping it easy is really important. No regular sort of in-person meetings, especially in the era of COVID, because they're always changing. Easy platforms, minimal time commitments, and that would be in line with research on education, doing something daily, not huge chunks, right? But that formative feedback scores, like the assessment component itself, if I told you you got a 3 for smoothness of motion, go fix that, that doesn't really help you, okay? So how do we move beyond just a score and saying it's linked to outcomes to actually getting people better? And how do we do it in a culture where people feel safe? So I'm a little bit over time, so I'm just gonna click through these, and I'm happy to talk about things more. But I would say there are a lot of things that individual surgeons can do, and all of us that are interested in this topic, you can be a champion tomorrow for all of this by taking some of these things into account. And if you are a leader, if you're a chair of your organization, if you have a division that you run, if you run a whole hospital, how do you assure surgical excellence among your larger group? How do you develop processes that incentivize and give space and time for these? How do you help people set goals for improvement? We have meetings all the time about what your RVUs are and how you hit it, but how many times do we have meetings about, you know, the technical aspects or the non-technical aspects of what you're doing in an operation? And so as we start to think about how we can change the future so that the culture of surgery embraces this video assessment, I think these are some of my thoughts. And with that, I will turn it over for some questions. Thank you for the podium.